Welcome back to this next video in which we are discussing cardiac arrhythmias. Okay, so we're still discussing supraventricular arrhythmias, those arrhythmias arising because of problems that occur above the level of the ventricles. So we've discussed sinoatrial node origin arrhythmias, atrial origin arrhythmias, and now we're going to discuss arrhythmias that arise because of problems within the atrioventricular node. Okay, so we're going to discuss the AV node and arrhythmias that can arise from the AV node. So the one that I want to discuss is what's known as AV nodal reentrant tachycardia, and for short this is abbreviated to AVNRT. Okay, so this stands for Atrioventricular Nodal Reentrant Tachycardia. I'll write it out in full. So the AV is of course is of course for atrioventricular, the N is then for nodal, and the RT is for reentrant tachycardia. And as the name suggests, this arrhythmia is going to arise because of a reentrant loop that is actually going to occur within the atrioventricular node. So this is atrioventricular nodal reentrant tachycardia, and it's going to result in far too high heart rate, i.e. tachycardia. So atrioventricular nodal reentrant tachycardia. Okay, so what we're going to get then is we're going to get a reentrant loop occurring in the actual tissue of the atrioventricular node itself. Okay, so I'm going to draw a picture for this because really to explain what's actually going to happen here we do need a picture. So firstly I'll start off by drawing once again my picture of the entire heart here. So I'll do this cross section as usual. So we'll draw on all four chambers here. So here is the left atrium, here is the right atrium here, and then we'll have the right ventricle here, and then let's have the left ventricle here. Okay, so now let's put on the AV node here. So let's have the AV node like so, and I'll also add on the His-Purkinje system. So here, this can be the bundle of His, and then it will split into the right bundle branch here, and then the left bundle branch here. That will help us later on. Right, so now what I want to do is I want to zoom in on the atrioventricular node, and I want to actually show a reentrant loop in the atrioventricular node. So something has gone wrong with the atrioventricular node. This atrioventricular nodal reentrant tachycardia, it's going to arise because of some pathology occurring in the atrioventricular node that results in a reentrant loop arising. So let's zoom now in on the atrioventricular node. So let's have the atrioventricular node shown here. Okay, this window through the atrioventricular septum, and let's say that there is some sort of scar tissue down, well actually no, I'll have it like this, in the middle here, which forms now the possibility for a reentrant loop, for the electrical signal to go round and round this loop here. So let's say that all of this has been damaged, so that now we've got a reentrant loop formed around the atrioventricular nodal tissue. So there is the potential for a reentrant loop here. Now, in atrioventricular nodal reentrant tachycardia, what happens is the actual arrhythmia occurs in episodes. So often what happens is people with reentrant loops in their atrioventricular node, often they will have a perfectly normal heart rhythm. Okay, normally there'll be a normal sinus rhythm. The sinoatrial node will be driving the electrical activity within the heart, and this won't be a problem. But then suddenly they will go into an episode of atrioventricular nodal reentrant tachycardia, where suddenly this reentrant loop will become actually participating in a circus rhythm, and that circus rhythm will take over, driving the electrical activity in the heart. Okay, so normally then, in these people with these reentrant loops in the AV node, what will be happening is the sinoatrial node will still be driving the electrical activity in the heart. Okay, so here is the sinoatrial node. I'll just add on the internodal conduction pathways, so the anterior one, the middle one, and then the posterior one. Here is the interatrial conduction pathway as well, Bachmann's bundle. And now normally what will be happening is the sinoatrial node will be generating action potentials at its normal rate, 1 every 0.8 seconds, and these will be propagating throughout the atria, okay, causing atrial contraction. Then they'll be arriving at the atrioventricular node, and what will be happening is, okay, yes, we've got this great big lump of non-functional AV nodal tissue in the centre, which might just be connective tissue, but the rest of this is all functional, so this will just conduct the action potential down, so like so, in this way. It will go down both of the different pathways, and you won't get a reentrant loop arising, because look, when the electrical signal comes down here and down here, they'll meet each other and then they'll cancel each other out, so it won't ever start forming the loop, and instead the electrical signal will then just be passed on to the bundle of His, and that will pass it on to the right and left bundle branches, and then you'll go on and get ventricular contraction. Okay, so that's how usually these people have got normal healthy heart rhythms, because even though there is this potential for a reentrant loop in the AV nodal tissue, it isn't actually participating in a circus rhythm when the sinoatrial node is usually generating the electrical signal in the heart. However, what can then happen is there is always this possibility that you will end up getting a circus rhythm going round and round this reentrant loop that is potentially there, okay, and then what can happen for, well, the trigger isn't really understood, but somehow what can end up happening is something can go wrong, and then you can end up with electrical signals going round this reentrant loop. So potentially, for one sinus rhythm, let's say, when the sinoatrial node generates an electrical signal and it propagates down to the AV node, let's just say that for some reason it doesn't actually go down one of the sides here. Okay, it only goes down one of them. So let's say it doesn't go down this way, it only goes down this way. Then what will of course happen is the electrical signal will pass up here, well, pass around here, and then it won't ever reach, well, it won't ever meet another electrical signal coming the other way, so it won't get killed. And then what can happen is it can go round, and if it gets round to the top again and these cells have recovered, then it can just go round and round and round. Okay, and that's not good. We now have a circus rhythm that has been set up here, a reentrant loop that is actually causing an electrical signal to go round and round it. Now what's going to happen, of course, is this is going to become the primary source of electrical activity in the heart. So the electrical signal will just go round and round this reentrant loop in the atrioventricular node, and of course every time it comes down here it will send off an electrical signal down the His-Purkinje system to cause ventricular contraction, and every time it gets up to the top it will then send off an electrical signal that will go up the atria, and this will be generating electrical signals at far higher rates than what the sinoatrial node will be generating electrical signals. So what will be happening is electrical signals will be propagating up from the atrioventricular node up the walls of the atria here, and even though the sinoatrial node will still be sending out electrical signals, those will be killed, because if you can imagine, what will be happening is you'll get electrical signals propagating up like this from the atrioventricular node reentrant loop here, and they will meet the sinoatrial node signals that are coming down like this, and they'll just both annihilate each other. So the sinoatrial node electrical signals won't make it down to the atrioventricular node. Okay, so even though the sinoatrial node is still throwing out electrical signals, they won't get down to the AV node. Okay, right. So this obviously can then drive a tachycardia, because it's going to generate electrical signals at much higher frequency than the sinoatrial node would, and they're all going to go down to the ventricles, and therefore the ventricles will be contracting at far too high a rate. And this sort of a tachycardia is known as an atrioventricular nodal reentrant tachycardia. Okay, so let's now have a look at the ECG pattern for someone in a episode of atrioventricular nodal reentrant tachycardia. And I want to stress that this is normally episodic, so it's not a continuous thing. Usually this occurs in episodes where suddenly the reentrant loop will actually start having a circus rhythm going round it, and then you'll go into a tachycardia period. Okay, right. So what will the ECG then look like when you're actually in the tachycardia period? Of course, when you're in the normal sinus rhythm, the ECG will look perfectly normal. So what will be happening then is the AV node is the source of the electrical signal, and it is sending it off to the atria and to the ventricles concurrently. So what you'll actually get is the P wave for ventricular depolarization will be on top of the QRS complex for the P wave for atrial depolarization will be on top of the QRS complex for ventricular depolarization. In addition, of course, the electrical signal is propagating up from the AV nodes. It's propagating in a retrograde direction. So, of course, the P wave will be inverted. So, what will it actually look like? It will look kind of like this. So, here is the QRS complex. There's the Q wave. And, of course, because this is a supraventricular tachycardia, the conduction through the ventricles in the His-Purkinje system is completely normal, so the QRS complex will look reasonably normal, apart from the fact that it's got this inverted P wave on top of it. Okay, so here is the R wave here, representing major ventricular depolarization as the electrical signal propagates from the subendocardial myocardium to the subepicardial myocardium. And then in the final bit of the QRS complex, the S wave, that's where you generally actually see distortion because of the fact that there's an inverted P wave on top of this. So this tends to look more like this. Okay, and this is because there's that inverted P wave on top of the QRS complex, and it's distorting the S wave, which would normally be like, well, it would normally be something like this, and it's distorting it out to this. So this is because we've got the inverted P wave on top of the QRS complex due to the retrograde conduction up the atria. And then, of course, you might get a bit of the T wave, which will represent ventricular depolarization, but usually what happens is this is so rapid that then you'll just go into another one of these, so you'll have another one straight after it. Okay, so this is what you might expect the ECG pattern to look like with someone in an episode of atrioventricular nodal reentrant tachycardia. Okay, right, so clearly this is quite dangerous because it can lead to the ventricles contracting at far too high a rate, which can damage stroke volume and hence cardiac output. And if cardiac output goes down, you are at risk of death. Okay, so how then do we actually treat atrioventricular nodal reentrant tachycardia? Well, firstly, what I want to talk about is drugs that we can use to actually terminate episode of the atrioventricular nodal reentrant tachycardia. As I've told you that this one is mainly episodic, so often these people are normally in normal sinus rhythm, and then suddenly the reentrant loop actually starts conducting a circus rhythm around it. So what we need is drugs that someone can take when they're actually in an episode of atrioventricular nodal reentrant tachycardia. So, and hopefully the idea is that these drugs will be able to return the heart to normal sinus rhythm. Okay, right. So firstly, actually, there's a few procedures that you can do to try and return yourself to normal sinus rhythm, and these are the vagal maneuver and the valsalva maneuver. So I'll just write these down. So here we're now going to discuss the treatment of atrioventricular nodal reentrant tachycardia. Okay, so treatment then, you can use the vagal maneuver and also the valsalva maneuver. And the idea here, and indeed the idea behind all of the drugs as well as these maneuvers, is that we are going to try and slow conduction down in the atrioventricular node. And let me explain why that will help. So we have got this reentrant loop going round and round the atrioventricular node. If we were to slow conduction down in the atrioventricular node, and we've seen lots of drugs that can do that, what would then happen? Well, this circus rhythm that's going round and round this reentrant loop of the AV node, it would now be going slower. Okay? Now, if it's going slower, then there is more hope that the sinoatrial node might be able to kill this. You see, the sinoatrial node is still sending off electrical signals at its normal rate. Now, the reason that the sinoatrial node is not killing this electrical signal that's going round and round this reentrant loop is because, remember, the electrical signal from the sinoatrial node only gets down a little bit of the atrial wall before it meets an electrical signal coming from our reentrant loop here, and therefore its electrical signal gets killed. But if we give drugs that will reduce the rate at which the circus rhythm will be propagating round this reentrant loop of the AV node, then the rate at which you'll be getting electrical signals chucked off to the atria and the ventricles will go down. And there is then the hope that the electrical signals coming from the sinoatrial node might actually get all the way down to the AV node. And if they get all the way down to the AV node, they will kill this circus rhythm. You see, the reason is, imagine now that an electrical signal has made it down all the way to the AV node, and it's activating this tissue here. Then if the circus rhythm is just coming up here, whilst the electrical signal from the sinoatrial node is coming like this, down here and down here, then you can see that the circus rhythm will meet the electrical signal coming from the sinoatrial node, and then it will be killed. So if we can get the electrical activity from the sinoatrial node actually down to the atrioventricular node, then that will kill the circus rhythm, and then that will be gone now. Once you've killed the circus rhythm, it's gone. So now what will happen then is the heart will return to normal sinus rhythm. So the idea then is that if we can slow down the circus rhythm occurring in the atrioventricular node, then potentially we might give the electrical signal coming from the sinoatrial node time to actually get down to the atrioventricular node, meet the electrical signal of the circus rhythm, and actually kill it in this way, and then will be returned to normal sinus rhythm. So the treatments here for an episode of atrioventricular nodal reentrant tachycardia are going to focus on trying to slow down the rate at which the atrioventricular nodal cells actually conduct action potentials. Now, there are two manoeuvres here that you can do to actually reduce the rate at which atrioventricular nodal cells conduct action potentials, which are the vagal manoeuvre and the valsalva manoeuvre. And the way that these are going to actually work is they're going to result in an increase in the parasympathetic nervous system excitation or signalling onto the atrioventricular node. So remember, parasympathetic nerves are going to release acetylcholine onto the atrioventricular nodal cardiomyocytes, and acetylcholine will work on the M2 muscarinic acetylcholine receptor, which then has the effect of slowing down the conduction of action potentials in the AV nodal cells. Okay, so the idea is, if we can increase the amount of parasympathetic stimulation onto the AV nodal cells, then we can reduce the conduction velocity in the AV node. And this is what the vagal manoeuvre and the valsalva manoeuvre are all about. So firstly, let me explain the vagal manoeuvre to you, and I'll just get a little bit more paper for this. So the idea with the vagal manoeuvre is that we are going to massage the carotid sinus. Okay, so firstly let me just remind you of a bit of anatomy. So the carotid sinus is in the neck, and it's a swelling, effectively, of the internal carotid artery. So let me just remind you of the anatomy of the common carotid artery. So let's look at someone's neck from the right-hand side. So let's say here I'll just draw a picture of someone's neck. So here is someone's neck, and then their face will be here, okay? And I won't embarrass myself by trying to actually draw their face. So here is their chin, and their nose will be here. Well, actually, I'm doing it now. There we go. Okay. So here is someone's neck, here is someone's head, and we are looking, obviously, from the right-hand side here. Okay, so the common carotid artery then, which is a major branch that comes off the aorta. Of course, in the case of the right common carotid artery, it comes off the brachiocephalic artery. In the case of the left common carotid artery, it comes directly off the aortic arch. Okay, so here comes the common carotid artery up the side of the neck here. So this is the common carotid artery, and then at about the level of the thyroid cartilage, what happens is the common carotid artery bifurcates into its two major branches. So this is the common carotid artery, and it's now going to bifurcate into two separate branches. One moves more forwards in this way, like so, and then one that moves more backwards, and I'll try and put the swelling here like so. Okay, so the one that sort of goes forwards, this one here, this is going to supply the external portions of the face, okay, and this is called the external carotid artery. Of course, this is the right external carotid artery. So I'll just put external carotid there. I'll colour it in. So this is the right external carotid here in red. Just try and make sure that there isn't that hole there in the side of my carotid artery. And then we've got our common carotid artery here in green. And now the other branch then, that we've bifurcated into, the one that's more posterior here, this is of course the internal carotid artery, and that swelling there, that is what is known as the carotid sinus. Okay, and this is what we're going to try and massage in the vagal manoeuvre. So this artery here is the internal carotid artery. Right, so the carotid sinus, its function is to monitor blood pressure. It monitors how high the blood pressure is here, and then if the blood pressure is too low, it takes action. It causes all sorts of responses all over the body to try and bring blood pressure back up. And if blood pressure is too high, it's going to cause effects all over the body to try and bring blood pressure down. Now, what we're going to aim to do is massage that carotid sinus here. And of course, if we massage that carotid sinus, we will trick the carotid sinus into thinking that blood pressure is far too high, because we'll be placing pressure with our fingers onto the carotid sinus. So then what will happen is the carotid sinus will take action to try and bring blood pressure down. And what's one of the major ways that you can bring blood pressure down? Well, by decreasing heart rate, decrease cardiac output, and you will decrease blood pressure. And how do you decrease heart rate and decrease the contractility of the heart? You increase the parasympathetic stimulation to the heart. So massaging the carotid sinus is going to result in increased parasympathetic stimulation onto the heart, more acetylcholine being released onto the heart. That's going to have this negative dromotropic effect. It's going to slow down the conduction of action potentials in the atrioventricular nodal cardiomyocytes. So that's the principle of the vagal manoeuvre, that you massage the carotid sinus to try and increase parasympathetic stimulation to the heart, in particular to the atrioventricular nodal cardiomyocytes. Okay, so you might wonder, well, how on earth do you actually find the carotid sinus to actually massage it? Well, quite simply, what you do is you take your fingers and you feel the side of the neck. So you can try this on yourself. So you can feel the right side of your neck, and what you have to try and do is you have to try and find your carotid pulse. Now this isn't too difficult to do, so you just need to place two fingers, sort of press them into the side of your neck, and try and feel carotid pulse. And where you find your carotid excuse me, where you find your carotid pulse most strongly, you'll then have your fingers over the carotid artery. What you then need to do, of course, is just go slightly lateral to that and push around. So you follow, the idea is that you will place your fingers and follow the common carotid artery and the internal carotid artery like this, and then you'll just go lateral to that and sort of push around all the way up and down the internal and common carotid artery. And the idea is that then you will eventually hit the carotid sinus, and you will end up massaging the carotid sinus. So it isn't an exact art. You don't sort of completely know where the carotid sinus is, but you just sort of press enough areas that eventually you will have hit the carotid sinus, and therefore will have increased parasympathetic tone to the heart. Okay, now of course you should only do this on one side at once, because when you're palpating the carotid artery in this way, you're going to be obstructing blood flow through it, and of course the carotid arteries are the main supply of blood to your brain, so you don't want to be blocking both of them off at once. That's not a good idea. Okay, so the vagal manoeuvre then, that's a way of increasing parasympathetic stimulation to the heart, and that will decrease the speed at which action potentials are conducted through the AV node, and the idea is then we can slow down the circus rhythm in the reentrant loop in the AV node, and hopefully then actually return the heart to normal sinus rhythm, because the electrical activity from the sinoatrial node might get that opportunity then to actually kill the circus rhythm that's going around the reentrant loop in the AV node. Okay, right, so now on to the other manoeuvre, and I'll just bring back up the piece of paper, this other manoeuvre which is called the valsalva manoeuvre here. So we've talked about the vagal manoeuvre, now the valsalva manoeuvre. The valsalva manoeuvre is quite difficult to describe. Again, the aim of the valsalva manoeuvre is to increase parasympathetic stimulation to the heart. If we increase parasympathetic stimulation to the heart, then the atrioventricular node is going to conduct action potentials slower, and that's going to hopefully lead to that circus rhythm being destroyed. Okay, but of course the approach in the valsalva manoeuvre is quite different to what you do in the vagal manoeuvre. So in the valsalva manoeuvre, everyone really has done this before, but it is quite difficult to describe. I certainly am not going to attempt to draw a picture of it. What you have to do is you have to breathe in, okay, so I'll describe how to do the valsalva manoeuvre. So you need to breathe in, so take a deep breath in, and then don't expire, so hold your breath, and then what you need to do is described as bearing down. And bearing down is what you would do if you were constipated and you were trying to defecate. Okay, so you now need to sort of push down as though you're trying to empty your intestines. You need to push your diaphragm down, basically. And that will end up increasing parasympathetic outflow all over the body, and in particular it will end up increasing parasympathetic stimulation to the heart, and therefore you'll get this negative dromotropic effect. So I hope that you have understood what the valsalva manoeuvre is. I'm not going to attempt to draw a picture, as I say. You can go onto other YouTube videos and you'll be able to get films of people actually performing the valsalva manoeuvre if you're still a little bit confused about what that actually is. But I hope the principle of what it will achieve is clear. Okay, so both the vagal manoeuvre and valsalva manoeuvre are fantastic because, of course, the patient doesn't need to inject themselves with anything, and it's completely safe to do, as long as they don't attempt to do the vagal manoeuvre on both sides at once. So those are fantastic, and they are very good at ending these atrioventricular nodal reentrant tachycardias. However, if they're not good enough, if that isn't strong enough to actually end the circus rhythm going round the reentrant loop of the AV node, we can use drugs to slow down conduction in the AV node. So of course we've seen these drugs before, so we could use beta blockers to reduce sympathetic tone onto the AV node cells by blocking those beta 1 receptors. That will slow down conduction in the AV node cells, or we could use calcium channel blockers. I'm going to introduce you to another drug that can be used to slow conduction down in the atrioventricular node, which we haven't mentioned before because it's not really used to slow down atrioventricular nodal conduction in the other conditions. It's used here because it's something that would just be delivered when you're actually having a problem. So the drug that I'm about to talk about, which is adenosine, isn't really a drug that you want to be taking on a chronic basis. So you don't want to be taking it regularly, but it can be used to end an episode of atrioventricular nodal reentrant tachycardia. So it's a drug that it's okay if you're just taking it to end an episode, but you don't want to be having to take it on a regular basis, which is why we wouldn't use it in the other examples of arrhythmias where we've wanted to slow conduction in the AV node. Okay, so the new drug that I want to talk about is adenosine, and this will be given by intravenous injection. Okay, so you do an IV injection of adenosine. Okay, so how is adenosine going to slow conduction in the atrioventricular node cells? Well, adenosine has receptors on the atrioventricular node cells known as adenosine 1 receptors. So adenosine can activate what are known as the A1 receptors on the atrioventricular node cardiomyocytes. So let me just draw one of these. So here, let's say this is our AV nodal cardiomyocyte. Then it will have one of these A1 receptors on its surface, adenosine 1 receptor, which is again an example of a G protein coupled receptor, so it has these characteristic 7 membrane spanning alpha helices. And again, we're not going to go into the actual molecular details, we're just going to do this on the cellular level. Adenosine binds to the adenosine 1 receptor and that then triggers a reduction in the rate at which the action potential is conducted along the cell membrane of these AV nodal cardiomyocytes. We're not going to go into the signaling pathways downstream of the A1 receptor and exactly how inside the cell this does lead to a reduction in the conduction velocity. We're just going to do it on the cellular level. Okay, so adenosine will bind to A1 receptors, and just like M2 receptors, which are the receptors for acetylcholine, this will then lead to a reduction in the conduction velocity of action potentials along the AV nodal cardiomyocytes. Hence we'll get a reduction in the speed at which action potentials are conducted in the AV node, and hopefully then will slow down the circus rhythm and give the sinoatrial node electrical signals a chance to actually kill the circus rhythm. Okay, there is one final drug that I'd like to mention, which can be taken on a chronic basis to try and reduce the severity of episodes of atrioventricular nodal reentrant tachycardia when they actually arise. Okay, and this drug is what's known as flecainide. Okay, now flecainide is going to work by reducing the conduction of the rate at which action potentials are conducted along the cells of the His-Purkinje system. So if I bring back up my picture here, so here is my picture of our heart here, and we know that the electrical signal, once it's gone from the AV node, when it's coming from the AV node to the ventricles, it's going to have to go via the His, the bundle of His here, and then into the bundle branches down here, and then through the Purkinje fibers to the actual ventricular cardiomyocytes. Okay, just like when we were talking about the conduction of electrical signals from the atria to the AV node, and we said that there was a maximum number of electrical signals that the AV nodal cardiomyocytes could conduct in a minute. Okay, so in order for the atrioventricular node cardiomyocyte to accept another electrical signal from the atria, the first electrical signal has to get a certain distance along the AV nodal cardiomyocyte. It's exactly the same principle for the bundle of His here. Okay, so for the bundle of His to accept another electrical signal from the atrioventricular node, the first electrical signal that it's given has to have gotten a certain distance away. Okay, so I'll draw a picture here. So we'll have our AV nodal cardiomyocyte, let's say here, trying to stimulate a bundle of His cardiomyocyte here. So let's say it has stimulated it once, and now the electrical signal, the action potential, is propagating along our bundle of His cardiomyocyte here. If this atrioventricular nodal cardiomyocyte wants to stimulate this bundle of His cardiomyocyte again, it has to wait until this electrical signal has got a certain distance away before it can actually do it. Okay, because if the electrical signal, the action potential, is still reasonably close here, then it will be preventing this membrane truly having recovered and being capable of conducting another action potential. Okay, so if we want to try and reduce the number of electrical signals that can actually be conducted from the AV node to the bundle of His, then we can slow conduction of action potentials down in the bundle of His cardiomyocytes. It's exactly the same principle as what we did between the atria and the AV node, but now we're doing it between the AV node and the bundle of His. Okay, so the reason we'd of course want to do this is that when the AV node is participating in these circus rhythms, when we're in an episode of atrioventricular reentrant tachycardia, then the AV node is going to be trying to stimulate the bundle of His to fire action potentials at a ridiculous rate. So we would like to try and reduce the number of those electrical signals that are actually going to result in electrical signals propagating down the bundle of His. Okay, so that's what we're going to be trying to do. We're going to try and reduce the rate at which the electrical signal is going to propagate along the cell membranes of these bundle of His cardiomyocytes here, which will hopefully then lead to fewer electrical signals from the AV node actually making it down into the bundle of His conduction system, and therefore fewer ventricular contractions. Okay, and let me just point out that when you're in normal sinus rhythm, when the rate at which the AV node is sending electrical signals to the bundle of His is perfectly normal, this won't cause a problem, because as long as this AV nodal cardiomyocyte here isn't attempting to stimulate the bundle of His cardiomyocyte here at a ridiculous rate, it will be fine. The previous action potential will have got far enough for the next one to come along and be conducted. Okay, so in normal sinus rhythm, this drug won't affect how many of the electrical signals will actually get down to the ventricles from the AV node, but when the AV node goes into one of these episodes of atrioventricular nodal reentrant tachycardia, then it will block a lot of those electrical signals and hopefully help to reduce the ventricular tachycardia. Okay, so that's what we're going to try and do then. We're going to try and reduce the rate at which the electrical signal is propagated through the bundle of His cardiomyocytes. How are we going to do that? Well, the bundle of His cardiomyocytes, they have a very different action potential to the AV nodal cardiomyocytes. They have an action potential just like the normal contractile cardiomyocytes of the heart. So let me draw a picture to remind you of what the action potential for a normal contractile cardiomyocyte, and indeed one of these bundle of His cardiomyocytes, is going to look like. So we start off in the resting state, so we'll have the electrical potential difference is around negative 80 millivolts here. Then what happens is when the electrical signal, and I'll just draw in a gap junction here, when the electrical signal arrives in the previous cardiomyocyte, which in this case is one of these AV nodal cardiomyocytes, of course we're going to get positive charge moving through the gap junctions that connect the two cardiomyocytes here. Okay, and that will cause the initial depolarization of the electrical potential difference in this bundle of His cardiomyocyte here up to around negative 40 millivolts. Okay, so here we've got negative 40, and then of course once we get up to negative 40, that then is the threshold potential for the opening of voltage-gated sodium channels. So remember this big difference. In the sinoatrial node and atrioventricular nodal cardiomyocytes, it's voltage-gated calcium channels that cause the upstroke of the action potential. In normal contractile cardiomyocytes and also in the bundle of His cardiomyocytes, it is voltage-gated sodium channels that cause the upstroke of the action potential. So now what's going to happen is voltage-gated sodium channels are going to open, and those will allow sodium ions to move from the extracellular fluid into the intracellular fluid, causing further depolarization, and you'll depolarize up to around plus 20 millivolts here. Then what will happen is the voltage-gated sodium channels will now be inactivating, not because we've reached plus 20 millivolts, but just because after you've gone beyond their threshold potential and they've been open for a very short period of time here, they just inactivate. They go into a further state where they're no longer conductive. It's really because when you move the when you move the electrical potential difference past the threshold potential for the opening of the voltage-gated sodium channel, the open state is just like a transient intermediate state. Really, the two states that the voltage-gated sodium channel can exist in are both closed states. There's the resting closed state, which is the state it wants to be in when the electrical potential difference is below negative 40 millivolts, and then there is the inactivated state, which is the state it wants to be in when it's above negative 40 millivolts. But to go from being in the resting to the inactivated state, it has to go for a transient intermediate, which is the open state. That's why it is in the open state for a short period of time, and that's the state where it's actually conducting sodium ions into the cytoplasm of the cell. We'll go through that more later on actually when we come on to the mechanism by which lidocaine works. Okay, right, so voltage-gated sodium channels will open and they'll result in the upstroke of the action potential, then they'll inactivate. Then what you get is the rapid repolarization phase, where some voltage-gated potassium channels that open very quickly, because voltage-gated potassium channels usually open extremely slowly, but there are some certain types that are activated very quickly, and they open reasonably early at this sort of stage, and again they will be activated to open at negative 40 millivolts. They cause this rapid repolarization phase here. Then what happens is the L-type voltage-gated calcium channels, which were also activated to open at around negative 40 millivolts, they start to open and they're reactance goes up and up and up, this starts to balance the movement of potassium outwards through those voltage-gated potassium channels that are currently open, and therefore you end up with a plateau phase where nothing actually really happens. Then the L-type voltage-gated calcium channels start to close and more voltage-gated potassium channels open, resulting in repolarization here back down to negative 80 millivolts. Okay, so that's what the action potential then looks like in one of these cardiomyocytes in the bundle of His. Now, the important thing to understand for our purposes is that the upstroke of the action potential here is done by voltage-gated sodium channels. Voltage-gated sodium channels are responsible for this portion. Now remember, the upstroke of the action potential is really important for saltatory conduction. Okay, so remember, saltatory conduction, we've been through this already previously, but I will go over it again because it's so important to understand this. Saltatory conduction is the concept that an action potential on a little portion of the membrane here in pink will cause an action potential in the neighbouring portion here, which will then cause an action potential in the neighbouring portion after that, and it will conduct along the cell membrane in this way. Okay, now why does it actually spread? Well, it's because when this portion undergoes an action potential, it's letting in lots of positive charge in the upstroke of the action potential. It's letting in lots of sodium ions in this upstroke of the action potential. Now, these sodium ions will then diffuse, well, positive charge will then diffuse to the intracellular portion underneath the neighbouring portion of the membrane and will cause depolarization of that portion of membrane and therefore an action potential there. Okay, so that's a reminder of the action potential in these bundle of His cardiomyocytes. Now let's come on to the drug flecainide and how this is actually going to slow conduction in the bundle of His cardiomyocytes. So flecainide does the equivalent of what those calcium channel blockers did in the AV node. Flecainide is a drug which binds to voltage-gated sodium channels and will block them. Okay, so it binds to them, and then when they open, it doesn't work, basically. The flecainide drug is there and it's blocking them. So it blocks voltage-gated sodium channels. So again, just like when we discussed the calcium channel blockers, we are not going to give flecainide in a dose where it would block all voltage-gated sodium channels. If you did that, it would kill someone. Okay, what we're going to do is give flecainide in a dose where you will block a certain fraction of the voltage-gated sodium channels. So we will expose our bundle of His cardiomyocyte here to a dose of flecainide such that lots of its voltage-gated sodium channels are now completely useless because they've got the drug bound to them. So we inactivate a certain fraction of them, and I don't know exactly what fraction you end up inactivating, but imagine that we inactivate, let's say, 30% of them. So every 3 in 10 of the voltage-gated sodium channels have now got this drug molecule bound to them, and they are non-conductive. Okay, they're not going to actually function. So we have effectively reduced the number of functional voltage-gated sodium channels in our cell membrane. Now, what is this actually going to result in? Well, when this pink portion undergoes an action potential now, what's going to happen? Fewer voltage-gated sodium channels are actually going to open because lots of them now have flecainide bound to them. Okay, only the ones that don't have flecainide bound to them are actually going to be functional anymore. So now the upstroke of the cardiac action potential is going to be smaller. So the actual depolarization you'll get here is going to be smaller. So it might now look something like this rather than what it previously looked like. So you might not get to the same level of depolarization anymore because you've got fewer voltage-gated sodium channels actually opening. Okay, the density of voltage-gated sodium channels is smaller. This means that the amount of positive charge that you're bringing in is going to be reduced. Okay, so the amount of positive charge you're bringing in the upstroke is reduced. That means that the area of membrane that you will now induce to undergo an action potential is going to be smaller. The influence that this portion of membrane here in red having an action potential occur there will actually have on the surrounding portion of the membrane is smaller. Okay, so you'll only affect a smaller portion of membrane now, whereas previously you might have affected all of this membrane in orange and caused that to all undergo an action potential now. Maybe you only affect half as much now, you only get half as far away. This portion will still undergo an action potential, but now this portion won't, which now means to get this portion to undergo an action potential, it has to be induced to undergo an action potential by this portion undergoing an action potential. So can you see that the process of saltatory conduction is now going to be much slower? So by reducing the amount of positive charge that is actually coming into the cytoplasm of the cell in the upstroke of an action potential, you reduce the rate at which saltatory conduction is actually going to occur. And when you do that, then the action potential is going to conduct along the cell membrane at a slower rate. So flecainide is doing the equivalent in these bundle of His cardiomyocytes as what the calcium channel blockers did in the atrioventricular nodal cardiomyocytes. And the difference is clearly that the upstroke of the action potential here is driven by voltage-gated sodium channels, whereas the upstroke of the action potential in AV nodal cardiomyocytes is driven by voltage-gated calcium channels. Okay, so flecainide then is a drug which we can use to slow down the conduction of action potentials in the bundle of His cardiomyocytes. Why is that a good idea? Well, it means now that the time that you have to wait for the action potential to get far enough away from this portion of the cell here that you can actually stimulate this bundle of His cardiomyocyte to fire another action potential is going to be greater. Okay, so the maximum number of electrical signals that can actually be passed on from the atrioventricular node to the bundle of His has been reduced. Okay, and that will then mean that even if you do go into atrioventricular node or reentrant tachycardia, that the number of electrical signals that this AV node that has the circus rhythm going around it can actually pass on to the bundle of His and therefore to the ventricles is going to be reduced, and therefore it's going to help prevent too bad ventricular tachycardia as a result of these circus rhythms in the atrioventricular node. Okay, so we'll have a break here, and in the next video what we'll talk about is atrioventricular reentrant tachycardia. So this was atrioventricular nodal reentrant tachycardia. We're going to go on to atrioventricular reentrant tachycardia, which is an arrhythmia that actually involves both the atria and the ventricles, which is the one that doesn't really fit into supraventricular or ventricular. It involves both of them, and it can result because of a syndrome known as Wolff-Parkinson-White syndrome.